Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
We're addressing today minimally invasive spine surgery, and the topic is a little bit narrow, so it's not very broad in terms of discussing back pain in general, but we might cover a little bit of an overview of things in general. But I was asked to basically address this concept of minimally invasive spine surgery. And most surgical procedures are gravitating towards being minimally invasive, and there's some reasons for that, and that is that the incisions that we need to make are much smaller, there's less blood loss, and as a result of making smaller skin incisions and tissue incisions, the amount of trauma to the normally attached muscles is much less, and so the scar is less likely to give you trouble later on. There's definitely less blood loss when we do minimally invasive surgery, and the hospital stay consequently is much, much shorter. As a result, the recovery from the surgical procedure, because we have not disturbed normal tissues, is much faster, and we hope that there are fewer complications. And we have a question mark across there, because the more or the less invasive we become and the smaller our incisions, the less we see surrounding structures which could be possibly injured in the process. So there's a bit of a trade-off in this situation. The disadvantage of doing minimally invasive spine surgery is the fact that sometimes the operating time is much longer than it would be for a regular operation, because when you do a regular operation on the spine and you make a big long incision, you can see a lot of things, and so you move faster. There's a bit of a learning curve if you are dealing with minimally invasive spine surgery. Some of our instrumentation is new, so we're always going back for more and more training. And that happens to all of your spine surgeons that are here in Washington Hospital. There's 4 of us, by the way. There's myself, there's Dr. Jan Hensdorf, who's an orthopedic spine surgeon. There's Dr. Sandeep Kunwar, who's a neurosurgeon, and Dr. Jenny Multani. And I'm sure at various times you will hear all of them speak. So currently there's 4 of us spine surgeons that are helping the community. The other thing that happens is that because these incisions are really tiny, we have to know exactly where we are, and so we use the X-ray unit a little bit more. So as a result, we get radiated more, and perhaps the patient gets radiated more. Now, for you, it's a one-time deal. For us, it's a 2 or 3 times a week deal. So we are very careful with our exposure and what we do to ourselves. And it does require a whole lot more equipment in order to get this procedure done. So moving on, what we're trying to treat with minimally invasive spine surgery in the lower back is low back pain. And currently there are about 3 to 6 million Americans that are on permanent disability because of this situation. It's the second most common reason for anyone to see a physician. And as the fifth most common reason to be hospitalized for treatment of this condition. It is the third most common reason for surgical procedures being done. And if you're going to ask me what are the first two, I actually don't know the answer to that. However, it will affect about 50 to 80% of American adults in their lifetime. And there's about a 2 to 5% per year rate of having a back pain at some point in time. Now, there are two distinct patterns of treatment of low back pain. One is pain that's localized to the lower back, and the second is low back pain with leg pain and sciatica. And both of these things are treated a little bit differently. For low back pain itself, the operative procedure is a bit more because we have to stop movement of a segment of your spine. But for low back pain with leg pain and sciatica, the operation is much more focused, and the main goal there is to relieve pressure on the nerve. Now, having said that, when we do take patients to surgery, probably 90% of the time, our main goal with surgery on the spine is to relieve pressure on nerves or nervous tissue. Nervous tissue meaning the spinal cord or the nerves that exit from the spinal cord. With our attempts at surgery, we hope that the back pain that accompanies this condition is reduced in intensity, but it doesn't always happen. And we generally advise our patients that when you are going through the surgical procedure, we may get the pressure off of your nerve, but you may have to put up with some back pain. Some of the non-surgical causes for back pain are things like sprain, strain syndrome, a facet syndrome, which is and I'll explain what the facet is. It's a little joint in the spine that sometimes gets inflamed and often does not require surgical intervention. Disc degeneration, if you have multiple levels of discs that are tending to wear out with age and they cause a bit of a backache, they don't always need surgical treatment. If there's a disc bulge or a disc rupture, that will need surgery, but about 80% of the time a disc herniation or a rupture can be treated non-surgically and go on to heal without surgical intervention. And then facet arthritis is a part of the disc degeneration syndrome, which can be treated with non-surgical means such as epidural steroid injections and increased weight bearing. I mean, this is I'm bringing this to everyone's attention that there's an emphasis in America to get people's weight down. The more weight you carry, the more pressure on your spine, and the more pressure on your spine, the greater the likelihood that the process of disc degeneration and facet arthritis will be accelerating. Some of the surgical causes that we can treat are things like disc herniations and rupture, and that's for that small percentage of patients that don't respond to non-surgical management. Spinal stenosis, this is a situation with aging that develops and is very amenable to surgical correction with excellent results. Spondylolisthesis is where the alignment of the spine gets disturbed, and that often requires treatment if it causes a great deal of back pain. Disc degeneration, largely treated non-surgically, but once in a while if the pain gets unbearable, then we have to take some measures to try and do some surgical procedures to treat it. A fracture of the spine can also be treated non-surgically a lot of the time, but once in a while will require surgical correction, and we'll address that in a minute. This is just a diagram to show you the pain pathways that that occur, that take place. And so this is the pain pathway, and pain is appreciated by nerve endings in the skin and in muscle tissue and in some of the tissues just below the skin and in all parts of your body. The nerves collect the information. They travel into the spine through this part of the nerve, which is called the dorsal root ganglion, and enters the spinal cord. And then the pain pathways cross over to the other side and ascend in these tracks that goes all the way up to this part of the brain, which is called the thalamus, and then eventually projects onto the main part of the brain where pain is appreciated. And I'm bringing this to your attention for a very specific reason. This is just a picture of the thalamus and a cross-section of the brain. And I wanted to emphasize that this is the white matter, and the covering over it is called the gray matter. And this is the frontal lobe of the brain, the part towards the front. The eyes up there, the ears are here, and this is the back of the head. So this lobe of the brain is called the prefrontal lobe. And the prefrontal lobe is important for your social interaction, doing appropriate things, making appropriate decisions and such. And we have noticed that people who end up having chronic pain have a tendency to start to develop some brain atrophy of the prefrontal lobe. The main transmitters that that are used in transmitting information from one cell to another are called neurotransmitters, and the endorphins are within your brain. They can get released when you have a pain situation developing, and you can enhance the production of endorphins by exercise and a high protein diet. Serotonin is another neurotransmitter which is within the brain, and its presence or absence is, or at least the depletion of the serotonin levels in patients who have chronic pain results in the development of depression. So if you can keep your serotonin levels up, it may help you cope with pain better. So one of the pathways that we use in trying to help patients deal with their chronic pain is to increase the serotonin levels by putting people on antidepressants. The antidepressants are not so much for actually treating your endogenous depression as much as it is being used by the pain doctor to help manage pain better. GABA is another agent that is a neurotransmitter, and it's in the peripheral nerves out by the skin and in the muscle tissues and such. And if we can modulate the use of GABA, then we can control pain a little bit better. And there's some GABA also affecting one brain cell to another. They help in neurotransmission essentially. And norepinephrine is the one that's way out in the periphery that is released when you have a pain stimulation that causes pain. Once again, picture of the brain showing the prefrontal cortex in this area and in this area. And this is the slide that shows that in 2004, some of the workers in University of Chicago discovered that there was atrophy of the brain that starts to develop in people who have chronic pain. And once again, to re-emphasize, it's responsible for making executive decisions, decisions that involve self-control, self-motivation, and inhibiting inappropriate behavior. So when you do have people with chronic pain and they start to behave somewhat differently in terms of tending to lose control of their tempers and such, it may actually be due to areas of the brain that are being affected by the presence of the chronic pain. One of the ways to counteract and get the endorphins to increase within your brain is to increase your amino acid intake. All of these chemicals within the brain are essentially proteins of different kinds that are made from amino acids. So if you increase your dietary protein, we might be able to achieve better pain control. Amino acids are required for the building and maintenance of and functioning of tissues. It is used as building blocks in muscle, bone, and hormones that are also influencing pain. And there are 3 neurotransmitters essentially exclusively produced by these amino acids, and those were the ones that I had mentioned earlier. These are some of the foods that should be eaten. You should have a high protein diet of 100 grams in a 2,600 calorie diet, and approximately 50% of your protein, is foods that contain more than 50% protein are poultry, seafood, beef, pork, lamb, eggs, and cottage cheese. And the vegetarians have a slightly greater need for doing something differently, because the green vegetables, beans, and nuts also produce proteins, but they need to supplement perhaps. This is a typical meal for a day that might help you improve and increase the endorphin production in your brain. It may help allow some of these neurotransmitters to form a little bit more fully, and it may be beneficial in the long run to help you manage your pain a little bit better. Now, to get on with the anatomy of the lumbar spine and the actual subject that we're going to be talking about, this is a little slide that shows the vertebral body. This is the disc, the disc is present between the 2 vertebrae, and its main goal is to keep the vertebrae spread apart so that the nerve that's running out through that opening, which is called the foramen, can run out easily. This part of the spine is called the spinous process, and it becomes important in a procedure where we implant a device to keep these 2 spread apart. This is the anterior ligament of the spine that holds the vertebrae together. Its importance is that when it's disrupted, there's a tendency for some instability to start to happen. This interspinous ligament is the one that we penetrate in one of our procedures that we'll be seeing a little bit later. And this joint is called the facet joint, and that's the one that tends to develop arthritic changes in it. And I would like to emphasize its relationship to the nerve. So there are times that when you have inflammation of the facet joint, but you don't have a disc herniation, but you still have pain that travels all the way down your leg because of the proximity of that facet joint to the nerve. This is just going on with the anatomy. This is the transverse process. This plate of bone is called the lamina. So in order to gain entry into the spine to get to the nerve, we have to remove this, and the facet joint. This slide I put up there to just show you the number of muscles and nerves that keep coming out from between muscle fibers that support your spine. And the emphasis on this happens all the way down your back as well. These nerve bundles come out and they run to supply the skin. So many times people who have neck pain and have tight muscles tend to have a referred pain and occipital headaches. It's related to the muscle tension. And so when we tell you to try and get the muscle tension resolved and your headaches may improve, it does relax some of the muscles that are running up and down your neck. And this slide is to emphasize once again the symmetry of the spine that runs up and down, and all the muscles attachment that we try not to disturb when we do spine surgery. So minimally invasive spine surgery is now taking off, and the main goal is to try not to disturb too many of the attachments of these muscles. If we're operating on the neck, mid-back, or the lower back, we try not to disturb this wonderful attachment of muscle fibers to the spine, so that in repairing whatever it is that we need to repair, we don't disturb your body to a greater extent. This is the anatomy of a disc. It's made up of an outer ring and a center part which is called the nucleus, and the disc develops little tears in it that can then result in a herniation of the disc, like so. And if the disc herniates, it can press on the nerve. Tears in the annulus, which is the outer ring, in and of itself can create back pain. And once a tear in the annulus develops, and it occurs again and again, it results in a gradual drying out of the disc, which then results in this process of disc degeneration. And when the disc degenerates, the two vertebrae come a little bit closer to each other. And so the openings through which the nerves run out become a little bit narrow. This is just a slide for the disc rupture. This is a slide of an MRI, which is demonstrating the discs in the healthy state, and the discs, when they become degenerated, they start to get desiccated. And this is just a general cause of back pain. In the cross section, we see the spinal canal through which the nerves are running, and we like to see it wide like that. When we need to do surgery on the spine, we do another MRI as a diagnostic test. We see the nerves running through here, and in this area we see a disc herniation sticking out, pressing on the nerves. And in cross section, that wide canal that you saw is obliterated by this rather large fragment of disc that is pressing on the nerves. So this type of person would require surgical intervention on the spine. Sometimes the facet will develop arthritic changes in it, and a little cyst will form. And this cyst can cause pressure on the nerve and cause sciatica. So this is another condition which is very amenable to minimally invasive spine surgery. When we have our patients with the back pain, our initial treatment is always non-surgical, and it's rest, anti-inflammatory medications, pain medications, some physical therapy, muscle relaxants. But when non-surgical treatment fails for more than 6 weeks, then we wish to consider surgical intervention. Now, surgery is an option. It's not mandatory. People can choose to stay non-surgical, and as long as the pain that they're experiencing is tolerable and doesn't interfere too much in your activities of daily living. And it is a choice that you make. It's not something that we mandate. So our first procedure that we're going to talk about is this procedure called a minimally invasive surgery called a discectomy. And I generally use this device called a Metrex system. It's done to treat lateral disc herniations where the nerve is being compressed. This is a picture of the spinal canal with the back part removed, and we see all the nerves that are running through there. We can treat disc ruptures that are causing pressure on the nerve at any level. When a disc ruptures, it causes pressure on the nerve, and then this is a picture of the various areas of the skin that are supplied by different nerves. So when we ask you where is the numbness, where is the pain traveling, and you tell us, we do get an idea as to which nerve might be involved. So it is very important for you to pay attention to that detail, because there are times that you may be having pressure on a nerve and you may be experiencing pain in one area, but the disc herniation may be off in a different area. And if the two don't match and you have a surgical procedure done, you probably will not get better. Everything has to fit together. This particular slide I actually threw in here just to show you the number of nerves as they run in and around the spine, so that you know that a disc herniation is just one of the reasons you could be experiencing pain. These are the facet joints, and there are a lot of nerves that run to supply the joints, and if you develop an arthritic change in that joint, you will have pain. If you move one segment of the spine on another, it will create pain by just stimulating those nerve fibers. And of course, if you have degeneration or wear and tear of this disc with tears of this annulus, you could be releasing chemicals into and around the nerves that can also be painful. So the disc itself is very acidic, and if you tear the capsule of the disc and a little bit of that fluid escapes to surround the nerve, you will have a lot of pain. The traditional operation used to be an open laminectomy. A laminectomy means removal of this plate of bone called the lamina, and here you see the extent of the surgery that was necessary, where the entire plate of bone has been removed. This is a bit of a destructive procedure, which we still do on occasion when it is necessary. But we, as mentioned, we are trying to get away from this, because in doing a laminectomy and removing this much bone and removing the support structures, we do tend to weaken your back. And we remove some of the ligaments that are attaching one vertebra to another. And so therefore, we would like to leave your back strong after we do a surgical procedure that takes the pressure off of the nerve. And hence the development of this microdiscectomy. Smaller incision, smaller laminectomy, discectomy, quicker recovery. We just want to remove this little fragment. Here's the nerve, here's the fragment of the disc that's pressing on the nerve, and as soon as we relieve it, the nerve is much happier, and we haven't damaged too much of the nerve. How do we do this? We start by passing we do put you under anesthesia, and we lay you face down on the operating table. And the first thing we do is we pass a wire through the skin pointing to the disc that we want to be at. That's the needle, that's the disc that we want to be at. Then over that needle we advanced a tube which is called a dilator, and that dilator is going through this large muscle. So back when we do a major operation, we divide the incision and we move this muscle aside and we cut its attachment to the bone. In this particular procedure, we are working through the muscle so that the muscle fibers still remain attached to the spine above and below. And we once again check it under X-ray control, and each dilator that we advance is a little bit bigger than the one before. So there's 3 or 4 different size dilators that we can advance, pushing the muscle aside further and further. Once we get that done, we put a final tube pointing towards the point of entry that we want to be at. And this is an opening. We're working through this channel, which is 18 millimeters in diameter. We have a microscope that we brought in to look through that tube, and we remove some of the bone. We get down to this nerve that's under pressure. We remove the disc after just displacing the nerve off of the disc. We remove the fragment, and we pull the tube out and the muscle closes over that opening. We may put 1 stitch or 2 stitches in the skin, and then we put a steri strip over it or a band-aid over it. And the size of that is about, that's a thumb, so it's about as big as your thumb. It'll give you an idea. This is the college that I went to for my high school years in India. The laser discectomy, every time I hit the website, the Laser Spine Institute comes up, and somewhere in Florida, I think. And they promote this laser discectomy. Now, like about 12 or 13 years ago, the laser discectomy became a very popular mode of treating the disc. And so I did take a course in it and trained in it and went ahead and used it in several people. And we have since abandoned its use because it doesn't remove that fragment of disc that's pressing against the nerve. It does do something. It dissolves the center of the disc, and so it reduces the pressure inside of the disc. But there are people that still perform the laser discectomy, and it does work at about a rate of 60 to 70% of the time. Whereas the microdiscectomy, which was the procedure that you saw earlier, that works about 95% of the time. So there's a very significant difference in the outcomes of the two procedures, which is why the laser discectomy is not promoted by it in the outcome measures when we are gravitating towards outcomes from different procedures and using that as a guideline for the insurance companies to allow certain procedures. The laser discectomy may not be one of those that is permitted. But having said that, you should know what is done. And this is an ideal, in a mindset, this is an ideal procedure to do, because you pass a needle through the skin into the disc, and through that needle you pass a laser fiber which burns some of the nuclear material within the disc. So whereas it doesn't actually remove the piece of disc that's sticking out, just by creating a hollow within the disc, it reduces the pressure against the nerve. And the hope is that as time goes on, that pressure against the nerve will be less, and therefore you will feel better. So once again, we put you under anesthesia, and this can be done under local anesthesia, by the way. A needle is passed into the disc, and we pass a tube over the needle, and then through that we can even pass a little instrument which will grasp some of the disc material, and you can pull some of the stuff out. And then the laser fiber is inserted through that needle, and we start to burn the center of the disc. And we can see through that, they've got microtechnology developed to the point that we can actually see what we are burning through that little tiny needle. But we can't actually see the nerve. We can just see the surrounding tissue that we are burning with the laser. These are my two mentors. One is Dr. Donald Doan, who was chief of neurosurgery at the Cleveland Clinic, and Ralph Cloward was a very innovative spine surgeon who practiced in Hawaii for many years and started a trend towards fusing the spine. We're going to move on to talking about lumbar spinal stenosis. This is why does it happen? Spinal stenosis is a condition where the spinal canal within the nerve, within the spine, starts to shut down. It gradually narrows down. And the reasons for spinal stenosis developing are the facet joints develop this inflammation. The capsule becomes lax. It may slip a little bit, and the joint itself becomes big and bulbous, causing narrowing of the spinal canal. Then there are age-related changes with some herniation and some looseness of one vertebra on another, which gradually causes narrowing of the spinal canal. And then the disc itself can develop those tears, which then start to cause disruption of the center of the disc, and the disc gradually will resorb, and calcium spurs will develop along the edges. So it's not just one series of things, it's a combination of three things that join together to create a narrow spinal canal. It happens in about 8 to 11% of people. It's one of the most common reasons why spinal surgery is done in the older population. And in 2003, there were 125,000 laminectomy procedures, which is the general, the main operation that used to be done. This is a picture of a normal spinal canal, and this is a picture of a narrow spinal canal that's developed as a result of facet arthritis and spinal stenosis developing from the disc bulging, from the facets getting a little bit bigger. The ligaments that hold the inside become very, very thick, causing nerve compression. This is an actual slide showing the normal side. This is the bone, this is the disc structure, the bone below, the spinal canal, and in stenosis, the disc tends to push out. This disc pushes out, narrows that spinal canal, resulting in pressure on the nerves. In the normal situation, when the disc is healthy and it keeps the bone spread apart a certain distance, this opening through which the nerves run out is wide open. Whereas in spinal stenosis, as this calcium spur develops, the joint becomes arthritic and this canal becomes distorted with the nerve then under pressure. With this condition, when you lean back or in extension, when you lean backwards, the spinal canal becomes narrower. When you lean forward, it becomes bigger. So what does happen classically in spinal stenosis is that people start to walk with a bent forward position. Once again, another very anatomical picture of showing a normal canal and showing a stenotic canal with the nerves getting crowded together because of thickening of the ligament and some of the disc material. An MRI scan of the spinal canal with slight narrowing at these levels and severe narrowing at this level. And in cross-section it shows, once again, the spinal canal has become this tiny little opening. So the canal is narrowed by a disc bulge, and in this particular series of pictures I wanted to show you what spondylolisthesis is. So as we look at the upper part of this, the slide, you see one vertebra lined up on the other one, but when this vertebra starts to slide forward, the canal, which is superimposed, starts to narrow just because the openings are offset a little bit. So this is called degenerative spondylolisthesis, and in days past we would always have to do a fusion on these patients. Now we can do a minimally invasive procedure which is called implantation of the X-stop. Once again mentioning, this is we can only do the implantation in patients who have the slip as a grade 1. That means they just slip a little tiny bit. It's 6 times more likely to occur between the 4th and the 5th vertebra. The process of disc degeneration is very, very slow, and the symptoms associated with spinal stenosis also progress very slowly through the years. So from one year to the next, you may not notice very much change, but a time does come when when you reach the point where you have back pain, and after you stand for a while, you start to have this feeling of weakness and heaviness in your legs, affecting the thigh muscles and the calf muscles, and you may progress to where you start to have tingling, numbness in the thighs or in the feet. And generally you start to reach for things like shopping carts so that you can lean forward a little bit, hold on to it, and get your shopping done. You feel much better that way. The moment you sit down, the symptoms disappear, and you wonder whether you really had that sense of weakness or whether it was just in your imagination. So the traditional treatment used to be a laminectomy fusion, or a laminotomy with facetectomy. Then these are just various terms to say that the opening was made bigger. But the minimally invasive approach to this now is this X-stop device, which is implanted to make the spinal canal a little bit larger. And so we start with the non-operative care of doing the epidural steroid injections, sending you to physical therapy, using anti-inflammatory drugs, and trying to get you to live with your pain, lose weight if necessary. And if those things fail, then we move on to implanting this device. So it works with these procedures that have to do with spinal stenosis. It can be done in people who have scoliosis as well. And in osteoporosis, we worry about it because the implant has to be placed, and the two bones have to support the implant. And if you have very soft bones, the spine may fracture. So we may have trouble with that. This is what the device looks like. It's got the main working channel is this cylinder that keeps the two spinous processes spread apart. And these two wings go on either side of the spine to help it remain in place. That is the device implanted on a side view. This is the opening which it is helping. It's helping that nerve to run out of that canal freely. This is the view from the back, and this is the cross-sectional view from the top. General goal is to try and make the canal a little bit wider. These are the devices that we use. It's a very simple single little toolbox which has got these dilators, a distractor, and then these inserting instruments. The operation is done with you lying on your side. It can be done under local anesthesia, in which case you go home the same day after about 2 or 3 hours. If it's done under general anesthesia, then we try and keep you in overnight for observation. An incision is made, the area is identified where we want to be. The incision is about 4 to 8 centimeters in length. There's a tissue plane that's on either side that is divided, leaving the center intact. And then we introduce one of these dilators and we rotate it through that ligament. This is a view of the ligament through which the dilator is being passed. This is the spinous process of the vertebra on one side, and this is on the other side. We double check it to see that we're at the right level, and we're aiming to place the implant as far forward as possible, because if it's too far back, it won't work and it'll dislodge and get displaced. Our next tool that we advance in there is called the distractor, which has got a gauge on it, and it's got these markings which tell us that when we spread it apart, what size of an implant we can use to keep those distracted. So that's the distractor in position and being inserted through. It's being spread apart, and we wait a few minutes for the ligaments to relax, and then we take our implant and we advance it through that opening that we made. Just another view of the implant, and then the locking screw with the additional wing is attached to leave the implant in position, and that's our final position, right up close to the vertebra, and this is the view from the back. So this is our latest device that we have been using for treatment of lumbar spinal stenosis. That is minimally invasive. The advantage is that we're not fiddling with any nerves very much at all, and so there's very little risk of nerve injury, and the amount of tissue damage to your bone structure is much less. It is done in an outpatient setting. It takes about 45 to 90 minutes to do. It can be done under local anesthesia. There's very little resection of bone and soft tissue structures. And if this device fails for any reason, we can always come back and do the regular operation. So that's the importance of it. But if we do implant the X-Top, we expect you to feel better the same day or the day after. And we expect the improvement to continue to occur over the next 3 to 6 months. If after 6 months you're still having substantial weakness of your legs, then we know that the X-Top is not the answer for you. We will bring you back and do the regular operation in order to get you treated. Some other options of treatment, I was going to talk about the X-Lift, but our main goal in doing spinal fusion surgery is in order to treat degenerative disc disease. I think a little bit later I'm going to show you a few slides on this technique of doing an X-Lift procedure, which is done from the side, to implant a device where the disc is. This is a minimally invasive way of doing a spinal fusion. Essentially, when we do a fusion, we create a living bridge of bone between two vertebrae. And so we come in from the side and we put a piece of bone where the disc is after spreading it apart. And then once we've done that, then we fix the spine from the back. And that involves implanting little screws with rods in position. Now, one of the things that has come up is this stealth station, which is a FluoroNav, and this is like a global positioning satellite system, because that's our satellite. It kind of looks at you, and we see the screen, like the Da Vinci, yeah. So this is a mobile imaging system, and it provides real-time movement of instruments that we can see where they're going. This is what an operating suite looks like. That's our satellite that's looking at the patient that's going to be lying there, and that's our TV screen that we are working through. And you can see that it gets pretty crowded in the operating room, but this is an actual patient whose incision is here. This is Dr. Hensdorf, that's myself, and we take these images with that satellite observing the images that we are developing, and we have some reference points that allow us to tell us exactly where we are. And this is the system that we use. We mark the skin, and we advance this device that gets attached to the spine, and this has got little markers on it that satellite is looking at, so that it'll give us a reference point to tell us where we are. So we can actually see the vertebra. We see these places, these circles here, which are called the pedicles, and we want to be, sorry, this device was in the wrong place. This is the pedicle, where we want to put a screw through there into the vertebra above and the vertebra below and attach the two with a rod. So this is our goal. We want to put the screw right down the bony tube into the vertebra without harming any of the nerves, and we want to do it with a minimally invasive approach. So with that camera guiding us, we watch our instruments and we outline the pedicle, and then we advance this a needle through that pedicle with this device attached to it, so that the satellite is, or at least that device is still looking, the camera is still looking at us, and we are watching where it's going. through the pedicle into the vertebral body. After that, we pass a dilator which pushes all the tissues aside, just like we did with the other instrument. The other operation, these dilators are being advanced through the muscle. And then we advance this tap. Once we've got everything into the right position, we advance the tap. Those of you in carpentry know what that is. We thread a screw through there. We advance our screw assembly device through that region into the area, and through that we're going to be putting a screw into the vertebral body. And then we attach this rod that slides through the skin. So actually, without making a very big opening, we advance a pretty large rod into the spine. And once we've got our screws into good position, we advance this rod through. We lock everything in place with this final tightening device and the set screw. And this is our skin incision, one on each side that's about 3 to 4 centimeters long, and one in the center to attach our array. So with this is our final construct. One rod on each side, 2 screws with the grafts in position where the disc used to be. And this will hold everything still until this vertebral body and this vertebral body will join together to become one. That's back in India. Nice place to visit if you ever get a chance. Just very quickly, our next thing that we do for treatment of vertebral fractures is called balloon kyphoplasty. If you have a fracture of your spine and the vertebral body has collapsed, we wait about 3 weeks after the initial onset of pain. And these are Medicare guidelines, essentially, that we have to wait 3 weeks, although they've just released us to do the procedure sooner if the patient is in agony. It's minimally invasive. It's done under general local anesthesia. Typically, it takes about 1 hour to get the fracture treated, and it may require an overnight stay in the hospital. Now, this is just an anatomical picture of the vertebra. Once again, if this is the fractured vertebra, we are once again approaching or trying to enter into the vertebral body through this bony tube, which is called the pedicle, and we want to put some cement into that structure. So that's what we do. This is a compression fracture where the vertebra has collapsed down. This is normal vertebra above and below. And we advance our device through the pedicle under X-ray control. We attach a balloon and we start to blow up that balloon, and the hope is that we can get it up to that height. And this is a artist's interpretation. We never quite get it quite that high, but we do achieve some restoration of height. And once we've created a space, it leaves a well-defined cavity that we can then fill with cement. So this is an X-ray picture before. The height has increased from 20 millimeters to 24 millimeters, and the cement has filled that space that was created. This is some X-rays that show the body immediately after the fracture and after the restoration of the height. This is a vertebra that has a tumor in it, and we can also use this to treat tumor invaded bone so that it becomes a bit stronger. Otherwise, it's very, very painful. So this is an excellent procedure that is useful for fractures and for making the bone stronger in the face of a myeloma type of tumor. Now, just about 3 to 4 weeks ago, there was a multi-center study that was done that was assessing the effectiveness of using cement into bone and comparing it with people who had a needle placed but no cement placed into the vertebra. This was a study. So they had an arm of the study where they had a sham operation. I'm not sure who volunteered for a sham operation, but there are people that volunteered for the sham operation. So some of them had the cement put in and some of them didn't have the cement put in. And they found that after a period of time that the two groups did exactly the same. So the conclusion was, and the San Francisco Chronicle and the Argus and all the newspapers jumped on the bandwagon and said that vertebroplasty is not effective. And so there were some patients that actually read that article and got influenced to cancel their operations. Now, vertebroplasty is a little bit different than the procedure that I just showed you, which is the kyphoplasty. Vertebroplasty, a needle is put into the vertebra, nothing is done to the fracture segment, and cement is injected inside to just make the bones hard right where they are. But the kyphoplasty procedure actually restores height, and so it's not equivalent. And I think that in all the studies that have been done in the past, the kyphoplasty procedure is still a very, very effective way of treating a fracture. So I would, before you go out and believe the newspaper, you should talk to your physicians as to what their experience has been with these procedures, because I still think that it's useful. It doesn't take away all pain, but it certainly makes the acute pain much more bearable.
Well, let's thank Dr. Erasmus. Thank you so much.